Welcome to the Rad Onc Smart Review GU Cancer Series.
It's great to be back talking about this.
Yeah, and today we're diving into something that is just, it's arguably the most rapidly evolving landscape in all of oncology right now.
Oh, without a doubt. We're talking about prostate cancer, but specifically across the entire metastatic continuum.
Right, from that first hormone-sensitive leap out of the pelvis, all the way to castration resistance, and eventually to, precision radioligand therapies.
It really is an incredible biological chess match because, in the 1940s, we realized you could just starve a prostate tumor of testosterone and essentially stop it in its tracks.
Yeah, Charles Huggins won a Nobel Prize for that, right?
Exactly. And for decades, androgen deprivation was basically the only weapon we had. But today, the moment that cancer escapes the gland, it enters this high-stakes evolutionary arms race.
It mutates, it adapts, it learns to synthesize its own hormones.
Yeah, it exploits alternative DNA repair pathways. Managing this is no longer just following a simple algorithm.
No, not at all. And if you're a resident, prepping for the oral boards or just a clinician trying to formulate a plan in tumor board, it is dangerously easy to get overwhelmed.
Oh, staring at the NCCN guidelines for advanced prostate cancer is like staring at a bowl of spaghetti.
It really is. There are so many overlapping phase 3 trials and new drug approvals. So our mission today is to fix that for you.
We need a guiding philosophy to cut through the noise, right?
Exactly. We're not just going to memorize a list of trials. We're going to unpack the underlying logic of why these tumors behave the way they do.
And to do that, you just need to stick to a core framework. It comes down to a really simple mnemonic, SPB.
SPB. I want you, the listener, to physically write SPB at the top of your notepad right now.
Yeah, it stands for State, Burden, Biomarkers, SPB. If you can define those 3 distinct parameters for every single patient sitting across from you, the management sequence practically writes itself.
Okay, let's break that down. First, state.
Right, state. Is the patient hormone sensitive, meaning the tumor still relies on testicular androgens? Or are they castration resistant, meaning the tumor has evolved to survive despite profound androgen depletion?
I got it. And second is burden.
Burden. Is it low volume disease or high volume disease?
And the third B is biomarkers.
Exactly. Are there specific genomic alterations or, cellular surface targets that open up precision pathways? State, burden, biomarkers.
That's BB. We are going to return to that compass at every single clinical inflection point today because the moment a patient progresses, one of those shifts and you have to pivot with it.
Absolutely.
So to demonstrate how to use this, let's ground the entire discussion in a single evolving clinical scenario. Let's introduce our case anchor.
All right, so you're evaluating a 67-year-old man in your radiation oncology clinic. He was referred by urology for a newly diagnosed prostate adenocarcinoma.
Okay, what's his functional status?
Functionally, he's doing great. ECOG-1, plays golf twice a week, just has some well-controlled hypertension.
Nice. But I'm guessing his workup is a bit more alarming.
Very. His presenting PSA is 84.
Whoa, 84.
Yeah. And on DRE, you palpate a hard, fixed left-sided lesion that feels like it extends cephalid right up toward the base of the left seminal vesicle.
Oof, okay. And the biopsy?
Grade group 4, so Gleason 4+4 in 8 out of 12 cores.
Right away, that is ominous. A PSA of 84 paired with high-volume grade group 4 disease. That's a massive red flag for systemic spread.
Completely. But before we look systemically, we need to map the local extent. So he gets a multiparametric pelvic MRI.
And what does a radiologist say?
They know clear left-sided extraprostatic extension breaking through the capsule. And they also note, quote, concern for early seminal vesicle involvement, unquote, on the left side.
Ah. Okay, this is a massively important clinical tool,
Right.
especially for anyone sitting in the hot seat during an oral board exam. The nuance of T-staging.
Yes, because when you see concern for seminal vesicle involvement, your immediate reflex is to stage him as CT3B, right?
Right, but jumping to that conclusion is a trap.
It is a critical trap. You have to be incredibly precise with your clinical staging language here.
So break that down for us. Why is it a trap?
Well, if the seminal vesicle invasion on the MRI is frankly obvious, like a massive low T2 signal tumor completely replacing the fluid-filled architecture of the entire SV, then sure, call it CT3B.
You can be confident.
Right. But if the imaging just shows extraprostatic extension with only early, equivocal, or, subtle signal changes at the very base of the SV, you are walking into an ambush if you firmly declare it CT3B.
Let's explain why that's an ambush for the listener. On an oral board exam, the examiner is listening closely to the exact stage you commit to.
Exactly, because that stage dictates your surgical and radiotherapeutic algorithms.
Right. If you say CT3B, you're definitively stating the tumor has invaded a separate anatomical structure.
And the moment you firmly commit to that, the examiner can drag you down a highly complex, highly morbid management rabbit hole.
Like pushing you on the feasibility of a radical prostatectomy.
Right. They'll ask, well, will the urologist have to widely resect the neurovascular bundles, guaranteeing impotence? Will they have to abort the surgery entirely due to fixation to the pelvic sidewall?
And if you're discussing radiation, they'll force you to defend exceptionally wide target volumes.
Exactly. Volumes that heavily irradiate the rectum and bladder base, which significantly increases the risk of late GI and GU toxicity.
The biological reality is that the base of the seminal vesicle is just a really complex anatomical juncture, isn't it?
Oh, very. Denonvillier's fascia is fusing right there. The neurovascular bundles are super close. I mean, simple inflammatory changes from a recent biopsy can mimic true tumor invasion on an MRI.
Or even just a benign bulging of the central zone.
Right. MRI is exceptional, but it has limits in specificity at that border, so it is clinically safer and board strategically smarter to say, I would stage him as CT3A based on the clear EPE with concern for early seminal vesicle invasion.
That phrasing is perfect. It shows the examiner you acknowledge the high-risk MRI findings, but you aren't boxing yourself into a hyper-aggressive treatment corner based on a fuzzy read.
Precisely.
Okay, so locally, he is CP3A with concern for SV involvement. Again, PSA is 84. We have to look systemically.
Right. So he undergoes a PSMA PET scan for definitive staging.
Let's hear the findings.
The primary prostate gland is intensely avid. There are 2 avid left external iliac lymph nodes. And crucially, there are 3 distinct bone lesions.
Where are they?
One at the T8 vertebral body, one at the L3 vertebral body, and one in the right iliac wing. No evidence of visceral disease in the liver or lungs.
And his baseline labs?
Completely normal. Hemoglobin, hepatic function, ALK-PHIS, all normal.
Okay, so we pull out our SBB framework state. He's newly diagnosed. He's never received ADT.
Right, so his tumor is entirely reliant on testosterone. His state is de novo metastatic hormone-sensitive prostate cancer, or mHSPC.
And that de novo part is critical, right?
And huge. It means he presented with metastases right out of the gate. That's inherently a more aggressive underlying biology than someone who had a prostatectomy, had 5 years of undetectable PSA, and then developed a MET.
Okay, state is defined. Next is burden. Is he low volume or high volume?
And to determine this, we rely on the classic charted criteria.
Right, let's outline the physiological basis of those criteria. Charted defined high volume disease as the presence of visceral metastases, like liver or lungs, or the presence of at least 4 bone metastases, with at least 1 outside the axial skeleton.
Exactly. Outside the spine and pelvis, if you don't meet either of those bars, you are low volume.
So applying that to our patient, he has 0 visceral mets. He has exactly 3 bone mets T8, L3, iliac wing. Because 3 is less than 4, mathematically he is classified as low volume.
By the strict classic charted definitions, yes.
Well, wait, here is where we have to stop and think critically about the technology.
Yes, because this is oral board trap number 1.
We mapped his disease using the PSMA PET scan. PSMA is highly overexpressed on prostate cancer cells, and our tracer binds directly to it.
Right, but the charted trial, which established these volume buckets, was designed back when we staged patients with conventional CT scans and technetium 99-meter bone scans.
And a conventional bone scan doesn't even look at the tumor cells. It looks at the osteoblastic bone reaction, the scar tissue.
It's a profound technological disconnect. By applying charted criteria to a PSMA PET, we are essentially mapping a 1080p standard definition framework onto a 4K ultra-high definition television.
That is a great analogy. A 2-millimeter marrow deposit that lights up brilliantly on a PSMA PT might not generate enough scar tissue to be remotely visible on a regular bone scan for another 6 to 12 months.
Exactly. So we were dealing with a massive Will Rogers phenomenon here. Stage migration.
Right, because our imaging is so sensitive, patients who would have been called M0 10 years ago are now accurately identified as having low-volume metastatic disease.
And patients who might have had 1 tiny invisible bone met are now showing up with 3. If our patient has 3 bone mets on a highly sensitive pH, There's a very real chance he would have had 0 visible bone mets on a conventional scan.
So if you just present this case to an examiner and blindly say he is low volume, they will dock you.
A sharp examiner will definitely dock you for failing to understand stage migration. You have to explicitly state the imaging caveat out loud.
How exactly should a resident phrase that?
You should say, based on the presence of 3 bone metastases and no visceral disease, he appears to meet the criteria for low-volume disease by conventional charted definitions. However, I would explicitly state to the tumor board that this was staged using highly sensitive PSMA petit, so we apply this low-volume label with caution.
Brilliant. It proves you understand the trial methodology, not just the bullet points. Okay, so state is de novo mHSPC. Burden is apparent low volume with the PSMA caveat. Before we treat, let's finish our baseline workup. You mentioned his hemoglobin and alkalosis were normal. Why do we care about those specific markers right now?
Every test needs a physiological rationale. We check a CBC looking for baseline anemia, which could indicate heavy marrow infiltration, or just serve as a baseline before myelosuppressive therapies.
Right, and metabolic panels.
We check renal and hepatic function because many of our systemic agents are hepatically metabolized. And OCFOS is a direct serum marker of osteoblastic bone turnover.
If it's elevated, the bone mets are actively remodeling the skeleton.
Exactly.
We also need a baseline testosterone level, right? It seems counterintuitive since he clearly has prostate cancer, but we need it.
We do. We have to prove he's not functionally hypogonadal at baseline. And more importantly, we need that baseline number so we can prove later on that our medical castration is actually working.
Right. We also rigorously document his functional baseline urinary stream, bowel function, erectile function, because our therapies will impact all of those.
If you don't know his baseline, you cannot accurately grade toxicity later.
But the most critical part of the modern baseline workup brings us to the third B in our SBB framework, biomarkers.
And this brings us to oral board trap number 2.
Because 5 or 10 years ago, genetic testing was the last resort, right? We waited until they progressed through ADT, progressed through chemo, and we're out of options.
The paradigm has completely shifted. The absolute standard of care is to order both germline and somatic genomic testing early. Right now, in the upfront mHSPC setting, you do not wait for castration resistance.
Let's unpack the biological why behind that. What specific genomic alterations are we hunting for?
2 main categories. First, mutations in homologous recombination repair genes, the HRR pathway, BRCA1, BRCA2, ATM, GT2.
Genes responsible for fixing double-strand breaks in DNA.
Exactly. If they are mutated, the cancer cell has a fundamental structural vulnerability. Second, we look for mismatch repair deficiency, DMMR, or high microsatellite instability, MSI high.
Meaning the tumor is failing to correct single-base transcription errors, creating a massive accumulation of abnormal proteins.
Right, and we evaluate this on 2 distinct fronts, germline and somatic.
Let's clarify the difference because it dictates different actions. Germline testing looks at the DNA the patient was born with, usually a blood or saliva sample.
Yes, and if we find a mutation there, every cell in his body carries it. This is vital for the patient, but equally vital for his family.
Cascade testing.
Exactly. If this 67-year-old has a germline BRCA2 mutation, his daughters need immediate counseling because their risk of breast and ovarian cancer is drastically elevated. His sons have an elevated risk of aggressive prostate cancer. You are treating the family unit.
And somatic testing.
That's testing the tumor tissue itself, usually from the biopsy block. We are looking for acquired mutations. The tumor might have genetically drifted and acquired a BRCA2 mutation purely within the cancer cells, even if his germline blood test is totally normal.
Tumors are highly genomically unstable.
Right. And we test early because these biomarker buckets dictate our precision therapy options down the line. Our most potent drugs, like PRP inhibitors, rely on knowing the status.
If you wait until he's heavily pretreated, bone marrow compromised, ECOG3, you might miss the window to safely administer these drugs.
Exactly. Order it on day 1.
So testing is ordered. Let's get back to our patient. He asks you, what systemic therapy do I need and how aggressive should we be right out of the gate?
Well, historically, the answer was just androgen deprivation therapy, ADT, as monotherapy. We'd drop his testosterone and just wait for the disease to figure a way around it.
That era is definitively over.
For a fit patient with mHSPC, ADT monotherapy is essentially medical negligence. The standard systemic backbone today is profound combination therapy. ADT combined with a novel androgen receptor pathway inhibitor, an ARPI.
Since he appears to have de novo low-volume disease, This doublet therapy ADT plus an ARPI is the bedrock.
Right. It's a dual blockade. ADT shuts down the factory in the testicles, stopping 90 to 95% of testosterone production.
But the adrenals still produce weak androgens, and the tumor itself can mutate to synthesize its own intracrine testosterone.
Which is where the ARPI comes in. Options like abiraterone, enzalutamide, apalutamide, and darolutamide.
Abiro is unique, right? It's a CYP17 inhibitor.
Yes. CYP17 is an enzyme required for androgen biosynthesis. By blocking it, abiraterone chemically halts production in the testes, adrenals, and within the tumor microenvironment itself. It starves the cancer from the inside out.
Whereas enzalutamide, apalutamide, and darolutamide are direct androgen receptor antagonists.
Right. They bind directly to the receptor on the cell surface with massive affinity. They block testosterone from binding, stop the receptor from entering the nucleus, and shut down transcription of growth genes.
Okay, I'm going to play devil's advocate. Our patient is 67, fit, ECOG 1. He has a massive PSA of 84 and Gleason 8 disease. I get the doublet therapy, but why stop at 2 drugs?
Ah, the escalation question.
Right. If we want to maximize survival, why not throw everything at it? Add docetaxel chemo right now, make it triplet therapy.
It's exactly the debate we have in tumor boards every week.
Yeah.
You're balancing cytoreduction against profound immunosuppression and toxicity. The strongest case for triplet therapy ADT and ARPI and upfront docetaxel comes from the Arescens trial.
Let's break down Arescens.
Arescens looked at adding darolutamide to ADT and docetaxel in the mHSPC setting. And it was successful. It showed a clear overall survival benefit for the triplet over just ADT and chemo. But when you look at the data across all our intensification trials, a biological pattern emerges. The patients who derive the most profound survival benefit from upfront chemo are those with de novo high-volume disease.
A burden dictates the aggression.
Exactly. If you have liver mets, meaning hematogenous spread, or 10 bone mets rapidly replacing marrow, you have a massive burden of rapidly dividing cells. That's where a taxane like docetaxel gives an immediate survival advantage.
Just like the original CHARTED trial, the survival benefit of docetaxel there was overwhelmingly driven by the high-volume cohort.
Right. The low-volume cohort in CHARTED actually showed no clear survival benefit from chemo. Conversely, trials like Latitude, which established abiraterone, showed hormonal intensification benefits both high and low-volume disease.
So for a fit, high-volume patient, triplet therapy is the absolute standard we recommend. But for our low-volume patient, how do you frame that discussion?
For him, triplet therapy is not an automatic reflex. It's a shared decision discussion. Docetaxel brings real compounding toxicity, neutropenia, severe infection risk, profound fatigue, neuropathy.
You have to ask if the incremental survival benefit is worth that immediate functional toxicity.
For the vast majority of low-volume patients, the answer is no. We stick with the highly effective doublet.
Okay, so systemic foundation is set, ADT plus an ARPI. But we're radiation oncologists. Where does radiation fit into this disseminated picture?
Radiation actually serves 3 completely distinct biological roles in advanced prostate cancer. Let's start with role 1. Prostate-directed radiotherapy for survival.
Because he's de novo low volume, treating his primary prostate tumor is standard of care. This completely upended our historical thinking, right?
It did. The paradigm shift came from the STAMPEDE platform, specifically ARM-H. For decades, the dogma was, if the cancer's in the bones, the horse is out of the barn, why radiate the pelvis?
Why paint the front door if the house is on fire?
Exactly. But STAMPEDE ARM-H randomized newly diagnosed metastatic patients to standard systemic therapy alone versus systemic therapy plus definitive radiation to the prostate.
And what did they find?
When they looked at the whole cohort, the dogma held no overall survival benefit. But when they stratified based on metastatic burden,
A fascinating biological reality emerged.
yes, in the low burden group defined similarly to CHARTED giving radiation to the primary prostate, significantly improved overall survival. The Kaplan-Meier curves separated beautifully,
And the STOP-CCAP meta-analysis confirmed this.
solidifying it as standard of care.
How does radiating the pelvis improve survival when cells are already in the spine?
2 main concepts, self-seeding and total tumor burden. The primary tumor is a dynamic factory. It acts as a continuous source of metastatic seeding. Even on systemic therapy, aggressive subclones in the prostate can mutate and shed new waves of metastases.
So you ablate the primary source to cut off the supply lines.
Right. Second, cytor reduction. The prostate harbors the vast majority of the tumor bulk. If you eradicate that with radiation, the patient's immune system and systemic drugs only have to focus on the remaining micrometastatic deposits.
It makes systemic therapy vastly more efficient. And we should briefly mention the Piece 1 trial context, too.
Yeah, Piece 1 looked at adding abiraterone and local radiation to a standard backbone. It showed that in low-volume disease, even with intensified systemic therapy, adding prostate radiation significantly improved progression-free survival and delayed serious GU symptoms.
The pure survival data for the boards is still Stampede RMH, though.
Exactly. So we are going to irradiate his prostate. But how? On the oral boards, you have to defend your technique and dose.
A safe answer is to cite a regimen modeled directly on Stampede. What were those schedules?
Stampede allowed 2 regimens, a moderate hyperfractionation approach, 55 gray in 20 daily fractions over 4 weeks, or an extreme hypofractionation approach, 36 gray in just 6 weekly fractions.
36 gray in 6 weekly fractions. That's 6 gray once a week for 6 weeks. It's incredibly pragmatic for a metastatic patient dealing with systemic fatigue.
Brilliant trial design. Now, for target volumes. Stampede mandated treating the prostate gland itself. Decisions about the seminal vesicles and pelvic lymph nodes were left up to the treating physician.
This is where art meets science. Our patient has bulky pelvic nodes on his PSMA PTT. Do we include the pelvic nodal basin?
On the boards, state that your volumes will be highly individualized. You can extrapolate from high-risk localized trials like POPRT and SP-PORT, which showed a PFS benefit to prophylactic nodal irradiation.
So for our patient with visibly involved nodes, a multidisciplinary discussion about including the pelvis is absolutely warranted.
But clarify to the examiner that the pure overall survival data from Stampede came primarily from treating the prostate itself.
Got it. Let's transition to role 2 for radiation.
Yeah.
Metastasis-directed therapy, or MDT. This is a fundamentally different clinical state.
Right. Let's use a hypothetical. Say a 60-year-old man had his prostate removed 5 years ago. PSA dropped to 0. Cured. But now his PSA is creeping up.
We get a PSMA PE, and we see exactly 2 bright lesions in his ribs, absolutely nothing else. Oligocurrent disease.
What's our goal here?
I like the agricultural analogy. You have a beautiful green lawn, and you notice 2 dandelions. You don't drive a tractor over the whole lawn and salt the earth. You spot treat the weeds.
Right. In prostate cancer, salting the earth is putting a man on continuous, lifelong ADT.
ADT is effective, but the metabolic toxicity alters a man's life. Hot flashes, visceral fat, loss of libido, muscle loss.
So if we can use stereotactic body radiation therapy, SBRT, to ablate those 2 bone lesions,
We can eradicate the macroscopic disease and delay the need for systemic ADT for years.
that perfectly captures the philosophy behind the MDT trials. It's a highly selected strategy for carefully chosen oligorecurrent patients. The goal is to alter the trajectory, delay progression, and delay systemic escalation.
The foundational trials here are STOMP and ORIOL. Let's dissect STOMP first.
STOMP randomized men with asymptomatic oligometastatic recurrence to either active surveillance or MDT. They found that MDT significantly delayed the time until they needed to start ADT. It bought them a median of 21 months of hormone-free life compared to 13 months with surveillance.
And ORIOL. That one had a fascinating imaging twist.
ORIOL was a randomized phase 2 in the U.S. It compared observation to SBRT to all visible lesions. It showed MDT significantly improved progression-free survival. But the crucial nuance, the part that shows you understand the biology, is how they handled the imaging.
They enrolled based strictly on conventional imaging, right? 1 to 3 mets visible on CT and bone scan.
Right. But every patient also received a PSMA PET scan.
But the radiation oncologists were blinded to the PT results.
Exactly. They could only target what they saw on the conventional scans.
So what happened when they unblinded the PET scans and looked at the overlap? What if the PT showed extra microscopic lesions that got left untreated?
The data was stunning. Patients with subtotal consolidation, meaning they had hidden PSMA-avid lesions left untreated, had significantly worse outcomes.
But those who achieved total consolidation, meaning the SBRT happened to hit every single site of PSMA-avid disease, had drastically better PFS.
It even hinted at an abscopal-like immune response in the total consolidation group. Right, changes in T-cell receptor clonality.
This strongly supports that if you're going to do MDT, you must use the most sensitive imaging possible to find every microscopic weed.
Yes, and we should mention Extend, which showed MDT improves PFS even when integrated with intermittent hormone therapy.
The absolute caveat for the boards, though, is that MDT is a selected strategy, not a universal mandate.
You don't reflexively shoot stereotactic lasers at every PSMA spot without a cohesive systemic plan.
Okay, so role 1 is primary prostate radiation. Role 2 is MDT for oligorecurrence. What is role 3?
Palliation, the bedrock of our field. If a patient develops a painful bone met, say, in the femur, causing pain with weight-bearing radiation is the most rapid, effective, localized pain medication we have.
The high-yield approach is simplicity, a single fraction of 8 gray.
It's so easy to overcomplicate palliative RT. We want to give 30 gray in 10 fractions because we think more dose is better, but the biology of bone pain relief doesn't need massive doses.
Radiation rapidly inhibits osteoclast activity and reduces the local inflammatory cascade.
And multiple randomized trials prove that a single 8 gray fraction provides equivalent overall pain relief compared to longer courses. It maximizes their time at home. Keep it simple.
Let's return to our case anchor and fast-forward his timeline. Our 67-year-old gets his ADT doublet and prostate radiation. He feels great for a few years. PSA is undetectable. But eventually, the evolutionary pressure forces the tumor to adapt.
The disease outsmarts the therapy.
We're entering progression. What is the explicit biological definition of castration resistance?
It means the patient's PSA is rising, or there's clear radiographic progression despite having maintained castrate levels of serum testosterone. In the U.S., that's a testosterone of less than 50 nanograms per deciliter.
This is a critical checkpoint. If the PSA is up, you must check the testosterone.
Because if the PSA is up, their testosterone rebounded to 200, they aren't castration-resistant. Your ADT drug is just failing.
Maybe they need a direct LHRH antagonist like relugolix.
Exactly. But if their testosterone is deeply suppressed below 50 and the PSA is still climbing, the biology has changed. The tumor has amplified its androgen receptors or developed splice variants like ARV7.
Which brings us to non-metastatic castration-resistant prostate cancer, CRPC. PSA is rising, testosterone is castrate, but conventional scans are completely clean. No new mets.
Do we just reassure him and watch the PSA climb?
The clinical decision hinges entirely on one kinetic metric, the PSA doubling time.
You calculate exactly how fast the PSA is accelerating. The pivotal trials here, Spartan, Prosper, and Aramis, all defined the high-risk threshold for intervention as a PSA doubling time of 10 months or less.
Why specifically 10 months?
Because historical cohort data showed that if the doubling time is faster than 10 months, they are at an astronomically high risk of developing overt, painful bone mets very soon. The disease is highly active.
Conversely, if it's 24 months, it's smoldering. The toxicity of adding drugs outweighs the benefit.
Right. But if his doubling time accelerates to 6 months, he crosses the threshold. You maintain the foundational ADT and add a newer generation ARPI, apalutamide, enzalutamide, or darolutamide.
Spartan, Prosper, and Aramis proved this improves metastasis-free survival and overall survival.
But eventually, the dam breaks. The PSA continues to rise, and now we see gross, visible metastatic progression on imaging. New bone lesions, new nodes.
The state has crossed into metastatic castration-resistant prostate cancer, MCRPC. This is where algorithms shatter into a dozen precision pathways.
And this is where we return heavily to the third B, biomarkers. Treatment selection is almost entirely driven by genomic biology and prior drug exposure. You do not just swap one ARPI for another.
If he progresses on enzalutamide, switching to abiraterone provides minimal benefit because the tumor already bypassed that axis.
Right. So we open the precision medicine map. This is where that early testing from day one pays off. Let's walk through the pathways, starting with DNA repair defects, BRCA mutations.
If we find a BRCA1 or BRCA2 mutation, we have a profound structural weakness. They can't repair double-strand breaks. We aggressively exploit this with PRP inhibitors.
Synthetic lethality. PRP repairs single-strand breaks. If you inhibit PRP, single-strand breaks degenerate into double-strand breaks during replication. Normal cells fix it. BRCA-mutated cancer cells shatter and undergo apoptosis.
It's a targeted, lethal blow. Trials like Propel and Magnitude support olaparib plus abiraterone or niraparib plus abiraterone.
And as a quick aside, this is moving earlier in the continuum. There's a new FDA approval for niraparib, abiraterone, prednisone, and ADT in BRCA2 mutated metastatic hormone-sensitive disease.
We're moving our smartest weapons to the front line. But back to MCRPC, what if it's a different HRR mutation, like ATM or CHK2?
The biology is similar, just slightly less exquisitely sensitive. The TALAPRO-2 trial established combining the PLP inhibitor talazoparib with enzalutamide for this broader HRR group.
And what if the mismatch repair system goes haywire, DMMR or MSI high?
That opens an immunological door. The tumor can't proofread its DNA, generating massive amounts of abnormal proteins or neoantigens. It places a neon target on the cell for the immune system.
But the tumor uses the PD-L1 checkpoint shield to tell the immune system to stand down.
Which is why we deploy immune checkpoint blockade, pembrolizumab. We strip away the shield, and the T cells slaughter the tumor. Pembrolizumab is highly indicated for any dMMR or MSI-high solid tumor.
Finally, the pathway that revolutionized our field. PSMA-positive disease. No BRCA, not MSI-high, but the PSMA PET is floridly positive.
We deploy radioligand therapy, lutetium-177, PSMA-617. Lutetium-177 is a radioactive isotope attached to a ligand that binds to the PSMA receptor.
It's a molecular homing beacon with a radioactive payload.
It binds, gets internalized, and emits high-energy beta particles, causing catastrophic DNA breaks right in the tumor, sparing normal tissue.
The VISION trial was the landmark here.
It established lutetium-177 as standard of care in highly PSMA-positive CRPC patients who progressed after at least one ARPI and one taxane chemo. Clear overall survival benefit. And trials like PSMA-4 are moving it to the pre-taxane setting.
We also have to talk about radium-2223 and oral board trap number 3. Radium-2223 is an alpha emitter, acts as a calcium mimetic going straight to areas of active bone turnover.
The ALS-YMPCA trial proved it improved overall survival for symptomatic, bone-predominant MCRPC with no visceral metastases.
But the massive trap is how you combine it. Researchers ran the ERA-223 trial, combining radium-223 with abiraterone up front.
And it was a clinical disaster. The combination arm had a profoundly increased risk of severe bone fractures and an increase in overall mortality.
It's an absolute black-and-white contraindication to casually combine radium-223 with abiraterone outside a trial.
If you suggest it to an examiner, you instantly fail.
Let's shift gears to toxicity, survivorship, and the functional trade-off. The biggest long-term trade-off is the insidious chronic burden of profound androgen suppression.
It induces a profound metabolic syndrome. Sarcopenia, visceral fat gain, unfavorable lipids, cardiovascular risk, fatigue, loss of sexual function.
And their skeletal architecture degrades. Which brings us to the bone health split. Let's test this logic. When our 67-year-old presented, he had 3 bone mets.
Should I reflexively start him on monthly high-dose denosumab right then?
No. You must intellectually split bone health into 2 distinct biological categories: fracture risk mitigation versus skeletal-related event prevention.
Explain the physiological difference.
Fracture risk mitigation is for anyone on prolonged ADT. Bone mets are not. Their baseline density thins, causing osteopenia or osteoporosis. We're trying to prevent a frailty fracture, like breaking a hip from a simple fall.
We recommend calcium, vitamin D, weight-bearing exercise, baseline DXA scan.
If the FRAX score shows high risk, we initiate standard osteoporosis dosing. Oral bisphosphonate or low dose, twice a year subcutaneous denosumab.
And the second category, skeletal-related events, or SREs.
This is vastly more aggressive. SREs are catastrophic events caused by the tumor destroying the bone pathologic fractures, spinal cord compression.
To prevent these, we use high-dose monthly denosumab or IV zoledronic acid.
But, and this is key, we reserve this monthly dosing specifically for the metastatic castration-resistant setting. Trials didn't show a clear benefit to initiating intensive monthly dosing in the hormone-sensitive setting just because bone mets are present.
So it's a staged approach.
Yeah.
Let's briefly unpack the specific ARPI toxicities. You have to map the toxicity to the mechanism, starting with abiraterone.
It blocks CYP17 in the adrenal gland, stopping cortisol production. The body senses this, pumps out massive ACTH, which shunts precursors down the mineralocorticoid pathway,
Resulting in severe mineralocorticoid excess, fluid retention, hypokalemia, hypertension.
To prevent this, you must co-administer abiraterone with a low-dose corticosteroid like prednisone to shut down the ACTH drive. Also, monitor liver function for hepatotoxicity.
And enzalutamide has a very different profile.
It's highly lipophilic, easily crosses the blood-brain barrier. It acts as an off-target inhibitor of GABA receptors in the CNS,
Causing profound fatigue, increased fall risk, and a rare but real dose-dependent risk of seizures.
Avoid it in patients with a seizure history or a recent stroke.
Apalutamide is similar, right?
Yes, but its unique side effects include a distinct maculopapular rash, likely an immune hypersensitivity, and significant hypothyroidism. Monitor TSH levels.
And darolutamide.
Structurally unique, highly polar, so it rarely penetrates the blood-brain barrier. It has a much cleaner CNS profile, lower rates of fatigue, falls, and cognitive impairment. Excellent for frail patients.
Exceptional breakdown.
Oh.
All right, we've covered an immense amount of ground. Let's synthesize this for the listener with a rapid-fire review, the board blitz. I'll set up a scenario, you give the definitive answer and the biological reasoning. Ready?
I am ready. Let's run it.
Question 1. 71-year-old man, de novo mHSPC, Conventional imaging reveals multiple liver metastases and a heavy burden of bone mets. He's ECOG-1, completely fit. Best initial systemic regimen.
The highest yield, most definitive answer is triplet therapy. ADT plus 6 cycles of docetaxel, plus an ARPI like darolutamide or abiraterone.
Specific reasoning for the examiner. Why not a doublet?
Because he explicitly has de novo high-volume disease, defined by visceral liver mets and heavy bone burden. In a highly fit patient, this is exactly the population where overall survival evidence for early, upfront cytotoxic chemotherapy from Arisons and Charted is strongest.
And prostate-directed radiation.
No proven overall survival role here. Systemic burden is too high.
Excellent. Question 2. 64-year-old man. Radical prostatectomy 6 years ago. PSA slowly rising. PSMA-PT shows exactly 2 isolated rib lesions. Hormone-sensitive, asymptomatic, terrified of ADT metabolic side effects, wants to defer it. Best next step.
Metastasis-directed therapy using SBRT to ablate the 2 rib lesions is a highly reasonable selected option.
What's the nuance for the examiner?
Present MDT as a selected, evidence-supported strategy, never an automatic reflex. Explain that in a carefully selected oligorecurrent hormone-sensitive patient whose goal is deferring ADT, MDT with SBRT is guideline-compatible based on STOMP and ORIOL to alter the trajectory and delay systemic toxicity.
Perfect. Final question. 70-year-old man, advanced MCRPC. PSMA-PT is floridly positive. Dozens of bone and nodal lesions. Heavily pre-treated, progressed through ADT, abiraterone, and docetaxel. Genomic testing shows no HRR mutations, no BRCA, microsatellite stable. Most appropriate next line of precision therapy.
Lutetium-177, PSMA-617.
Break down the logic of why the others are incorrect.
He perfectly mirrors the VISION trial criteria. Highly PSMA positive, progressed after an ARPI and a taxane. No BRCA or HRR means no PRP inhibitors. Not DMMR means no pembrolizumab.
And radium-223.
The prompt didn't specify visceral status, but radium doesn't treat as extensive nodal disease. Lutetium-177 is the clear, precision-guided, survival-prolonging answer.
That is how you pass the oral boards. Let's pull everything together. The entire landscape is anchored by SPB state, burden, biomarkers.
Always definitively state the state. Hormone-sensitive or castration-resistant. Define the burden, low or high volume. And explicitly state the imaging caveat if you used a PSMA PET.
And let biomarkers dictate the precision path. Early testing on day 1.
For mHSPC, we aggressively intensify upfront. Triplet for fit, high volume. Prostate-directed radiation in de novo, low volume based on STAMPEDE.
We use MDT as a precision scalpel for oligorecurrence. We track NMCRPC progression with a PSA doubling time of 10 months. And for overt MCRPC, we sequence based on biology, BRCA, HRR, MSI, PSMA, not blindly swapping pills.
And underneath it all, we manage survivorship, mitigating osteoporotic fracture risk early, deploying heavy-duty SRE prevention late.
Before we wrap up, let's leave the listener with a slightly provocative thought. We discussed how targeted weapons like PRP inhibitors are moving earlier right into the hormone-sensitive setting.
The logic is to hit the cancer with our smartest weapons on day 1 before it builds a heterogeneous clonal population. But think about the intense evolutionary pressure that creates.
Right. If we wipe out the BRCA mutated clones immediately, what exact biological phenotype is left over 10 years later when they inevitably develop castration resistance?
Exactly. We are going to see entirely new, incredibly aggressive neuroendocrine or anaplastic resistance pathways emerge. The MCRPC we treat 10 years from now will look genetically nothing like the MCRPC we treat today.
How will we rewrite the salvage algorithms when the cancer has already survived our very best targeted therapies from the beginning? That is the frontier.
It's a continuous escalating arms race. You have to understand the underlying biology, not just memorize flowcharts.
Complete practice oral boards at radonsmartlearn.com and subscribe to Rad Onc Smart Review for our next episode. Thanks for tuning in.